Hello, everyone. Welcome to the VGM podcast, and you get two special guests today with me, Rhonda Burmaster, and my counterpart, which is, who are you? It's been awesome having Kim on board at VGM the last, I don't know, it's almost 2 years now. So we've really appreciated having her on board, especially me, but I know our members have. So there's been a lot of value having both of us on board with helping our members out in the areas that we help at, right? Like there's all kinds of stuff we do. So today, guess what we get to talk about? It's still lingering. You guys remember that pandemic that happened, 5 years ago? March of 2020 is when it was officially, as far as CMS and flexibilities. Yeah. Guess what? It's still lingering. Just as we thought it was over with, it's not. It's still here. Not that we're in the pandemic by all means, and thank goodness, right? But we have some updates to share with all of you on what's going on with that and where we're at with the 5 years. We're now it's May of 2025, so it's officially 5 years ago that this all started. So the reason that Kim and I wanted to do this podcast and share some news with all of you is because of that. It's been 5 years, and we wanted to make sure that you understand some of the rules that are out there as you reach the 5-year RUL for these patients that initially qualified under the pandemic, and then some other information that we wanted to make sure you understood. So we know you'll get patients now that'll say, hey, I want a new CPAP or oxygen or whatever it is, and maybe they were under the pandemic qualifiers, which we had those flexibilities. And now what do we do, right? So when was it? In April of 2025, the contractors, CGS and Noridian, both released an article. And this is actually kind of what triggered us to say, oh, yeah, it's been 5 years. We need to talk about this and what's going to happen, because we know there's going to be questions on what do we do. So those patients that initially qualified under the pandemic with the waiver. So let's say you had a new oxygen patient with a CPAP machine, for example. The patient didn't meet all the criteria because we had those flexibilities in place. You appended the CR modifier and the claim narrative had COVID-19. Now it's 5 years and they want a new machine. Well, do you have to meet the new initial coverage criteria? What do you think, Kim?
I think not.
Right. Yeah. We wouldn't want patients to go through that, right?
So this is actually good news. We're delivering good news today.
Rarely do we do that, right? So those patients that, if you had the CR modifier on those claims when they got the equipment initially under one of those policies that had flexibilities, and it was because of the pandemic, they used whatever the flexibility was at the time, and it's 5 years. And the example we have a few examples we'll go over, but one's like a CPAP. Now it's 5 years. It's, May of 2025, and they want a new CPAP. They can get a new CPAP, but it's a replacement. So all you have to do is follow the replacement guidelines. So most policies have those guidelines in place. So you don't have to do new initials. It's just a replacement. So remember, traditional Medicare, when they do replacement, they look at things as, if the patient had it for 5 years, that means they've been using and benefiting if they're asking for it again, normally. And so you just follow those replacement guidelines. So the CPAP one is one example. We have a few others we'll go over here in a little bit, but CPAP is just that new visit and then a new order, and then obviously a delivery ticket for that replacement machine. So that's really good, right? Is there anything you wanted to add to that, Kim?
No, I think it's great that we can say without a doubt that new testing is not necessary.
Yes.
That should eliminate all the gray in the policy.
Yep. And the Max did a really good job with this article, and we'll make sure it's included in the show notes so you'll have an easy access to the link. We know that the links are on their news feeds, but if we understand, because we both came from the supplier world, that you're in a lot of day-to-day operational things, just putting out fires all the time. So we'll make sure it's included so that you can read this article and then share that article and this podcast with your staff so they know when they get one of these patients what they need to do. So I guess, because you're so good at the systems, Kim, and how they operate, what would you say, like, even if a supplier wants to stay ahead of this, instead of waiting for the patients to come to them and say, hey, I want a new piece of equipment, it's been 5 years, what would you recommend, like, if they wanted to stay ahead of it?
So for sure, the recommendation is to be proactive. Depending on how your systems are set up, hopefully, let's just use oxygen, for example. You have your system set up that the initial period is 1, the end period is 60, since we're married to them for, those 5 years. If it goes to 60, technically it will go on a stop hold report, and hopefully you're working your stop hold report. But when working with members, we really want them to be more proactive for that so that you're not losing a month or two of revenue. So there's a couple ways to do it depending on what system you are, but make sure your reports, and you could reach out to us. We're more than happy to help you with that. But make sure your reports, and I would start with oxygen particularly, you want to start at month 58. You want to start calling them, let them know that this process is going to happen, and then proactively get them into the mix. And there's lots of other details to that, but in general, that's what you want to do. You can look at an active rental report and you can see what month they're in so that you know when they're coming up. So there's lots of ways that you can do that.
Absolutely. And that's what's great about having technology, right? Is the flexibility is of running these reports and being proactive, providing the education because the tools are there.
I was just going to add to that. So with your systems, make sure that when you're entering a new order, you have a way to capture your other capped rentals. So CPAP the flexibilities are a little bit different. It's going to go from 1 to 13 with most insurance companies in general, but you still want to make sure that you're getting them close to that 5-year mark. And there's ways that you have to put things in operationally to make sure that you can actually recover some of that stuff.
Yeah, for sure. And one thing we want to make sure suppliers know is that you want to check the payers. We know that there's been a lot of flexibilities, and traditional Medicare, or some call it Medicare fee for service, they're really good about putting the articles out, and we know what those rules are. This information that we're talking about applies to that traditional Medicare or Medicare fee for service. If it's another plan, a commercial plan, a Medicaid, you want to refer to their own policies because they can do things a little differently at a state level or with these other plans. So make sure you follow that. Don't assume that they're all going to follow the federal level with traditional Medicare. Most may, or many may, I should say, but don't just assume that, right? Yeah, so stay ahead of it, with running your reports, knowing which policies did use these flexibilities when we had the pandemic, which I can't believe it's been 5 years and we're still talking about it, but it's been 5 years. And it ended, actually, the official end date of these flexibilities was May 11th of 2023. So even those flexibilities have ended over 2 years ago. When we look at these flexibilities with the CR modifier, it's just the policy that they're talking about. So the coverage criteria, not the proof of delivery with getting a signature, because we still have suppliers today that think, oh, we can just drop it off and not worry about a signature. Nope, those are gone. If you do that, and if you have an audit, guess what? They're going to ask for all that money back or not even pay you, depending on whichever type of audit it is, prepay or post-pay. So get the signature from the patient if you're doing direct delivery or in-store pickups, that they have to sign it. There's no excuse. Honestly, there's no excuse. Right?
Agreed.
Yeah. So let's talk a little bit about telehealth, because that's part of the pandemic too, right? We had telehealth flexibilities during the pandemic, which was great. We still have those flexibilities right now, which is great, right? We love that because many of our customers or our patients use telehealth for visits, and that's easy to do, especially with some policies like CPAP, BiPAP, those ones that you don't really need to go in and see a physician, which they still can, but those flexibilities are still in place through the end of the September. I almost said the end of the year, but that's not the case. The end of September, so September 30th of 2025. So that means that the patient can do a preferred as audio video with their practitioner, and then audio only is acceptable if the patient doesn't have video capabilities. That is fine. CMS has clearly identified that in their materials when they talk about telehealth. But just know it's available. So don't be afraid to use it. We've had suppliers, and I don't know what you want to share on this, Kim, but we've had suppliers that get really worried, which I appreciate, but they overanalyze the telehealth piece because they're like, they're worried about it not being a valid telehealth. And I've had experience personally as telehealth visits, which I love. I'm sure you have and others, but it's just when you look at the documentation from that referral, it's just making sure that it's a valid telehealth. And it'll say that usually in bold at the top of the visit notes of it being a telehealth and what was done, like they verify who you are. So I appreciate suppliers wanting to make sure that it's valid and legit, but we don't need to overanalyze that because we're not billing for telehealth. That's for that clinic to be billing for that, right? So I don't know if there's anything you want to add to that.
No, I think it's a great option, and it's an option, we don't, in this industry, we don't often get little breaks. And so this, I think, it provides us flexibility so that we can get our claims moving. Before, there's so many delays, even before the pandemic, there were so many delays for us billing our stuff because they couldn't get into the doctor. So I think it's a great thing. It's a win for us, or at least that's why the way I'm taking it. And then having that helps us with all, even outside of the pandemic, with all, RULs and these 5-year RULs. If you're not doing them, you need to start doing them. It is cash. And it's one of the things the insurance company says, hey, here's a way to make money. Go do it.
Yeah, for sure. So even with telehealth, because one question we often get from suppliers is if a patient did utilize telehealth with their practitioner to discuss their coverage or continued need, whatever it is, there's no additional modifiers. I mean, it's a visit. That's all it is. It's a visit. We don't have to worry about identifying that on a claim for our sake under the DME benefit. So just know that we are hoping this gets extended or permanent in language, because the current language is still in that statute where it says that we need the originating site. So it's mostly for rural patients that have to go, they need a specialty clinic or physician and they have to go to the originating site and all this stuff. That still exists, but it takes legislation to change that. And our government team with Isaacson and Adam Miller and Emily, they're all pushing with other stakeholders to get that language changed. It seems like it has good momentum, but until it's officially signed, you never know, right? But we do think it'll get changed. That was kind of the plan, that after the pandemic, once the flexibilities got extended, they talked about extending it a few times, kicking the can a few times, and then it essentially would become permanent. So we hope that still is the plan, but again, we don't know until it's officially signed and changed. But until then, we know we have till September 30th to use the telehealth flexibilities and with our patients. So use that. So any policy that says in person or face-to-face, telehealth is available, audio and video. Ones you'd want to consider like PMDs, I don't know if, because there's a statute with them, if that would be still, I think it is with PMDs, but I'm not 100%. We can check on that. That's why we have Dan Fedor on the US Rehab side. We can always check with Dan. He's the PMD guy. I can look up stuff, but why? We got Dan. But let's see, what else did we want to talk about on the pandemic? There was so much on the pandemic that it's crazy to think that we're still talking about it 5 years later. Do you have anything else?
No, I think if there's one takeaway from this, go run your reports now, tomorrow, as soon as you hear this, and then start while we still have some of the flexibilities.
Yeah. This is even why we had said when the pandemic was coming to an end, is to make sure you save a lot of these LCDs or these articles, anything related to the pandemic, keep them on file, because if there is ever an audit, which we know they're happening, I'm not worried about the DME Max because they're pretty easy to, I'm gonna say easy, but they are pretty easy. They're easier to work with than some of the other other contractors. But these other contractors don't always know all the rules or flexibilities that were in place at that time, depending on the date of service of that claim. So that's why we always encourage to save these things, because it'll get archived. And that's what the Macs have done with a lot of the pandemic stuff, is archived it. So you got to do a little bit more digging to find it. But at least you have this article that we'll have in the show notes that you can reference. And then, you can let us know if you have questions. But one last thing too, before we go, is we asked this question at a recent state show that we were at, and we said, is the CR modifier applicable only to the pandemic? And 50% of the people in the room said yes. And we're like, nope. But it was kind of a trick question because it wasn't really, I guess, asked right. I don't know, but I like to be tricky. I don't know. Yeah, right. Don't we? We like to play that game. But it's not. We're in a season, in the spring in the Midwest, like in Iowa where I'm at, and Kim's out on the East Coast and PA, they get a lot of rain, so there could be flooding or, hurricane-like weather they get, I think, sometimes. But the CR is applicable to a natural disaster too. So if you're getting hurricanes or the floods or the tornadoes or the fires that California get it in the fall, the CR is applicable to that. When federally they say it's a natural disaster, the difference is that when it's one of those natural disasters, we don't have all the flexibilities we had during the pandemic. We only have a replacement policy that has some leniency. So just keep that in mind when you're talking about a flood, fire, hurricane, whatever it is that's become a natural disaster, and you put CR on the claim, and in that narrative you're saying Hurricane Milton or whatever they are, that's usually about a replacement. There's some flexibilities with replacement. That's it. With the pandemic, remember, we had a lot of options with our policies. So keep that in mind, not to be confusing, because I feel like I keep talking and talking and I'm like, land the plane, Rhonda, land the plane. But just know there's some differences. But this was more about the PHE, and it's still around, and the RULs, and what Kim talked about, running your reports. So making sure you're doing that, staying ahead of the game, and getting those patients taken care of now rather than later. So look at the article. You'll see the policies that were included in this particular flexibility that the MACs are talking about. You'll see this, so you can start seeing what different products that you're offering, and you can start running those reports. We're here to help. So, if you have questions, our contact information is out there. You can get a hold of us, or if there's an easy way, I forget what that email is. What is that, Kim? Like the general one we use?
rcs@vgm.com.
That's right. Yeah, we both get that. So that's easy. So yeah, I think that's really it that we had. So just take a look at that article and listen to this a few times, because we like it when you listen to us. And that's it for now. Thanks, everyone.
Have a good day.